In the case of pediatric MOG-associated disorder or MOG antibody disease, and it's being called both, one of the most important things is the ability to distinguish a child who's destined to have a single event, often with quite good recovery, from a patient whose first attack is simply the first of many. And right now, we really don't have biomarkers that do that. One would like to think that the titer of the MOG antibody might be helpful, but it is actually not. MOG titers are high at the time of an incident attack and then rapidly decline in many patients. And this bears no obvious predictability on the likelihood of a second attack. We have recently published that in the first 6 months after an initial attack of MOG-related disease, new lesions can appear on the MRI, often small lesions that sort of are shown in the first few months. And these do not reliably predict the likelihood of further attacks either. Unlike in multiple sclerosis, where the presence of new lesions is pathognomonic of relapsing disease, at least in pediatric MOG, this may not really be the case early on. Studies looking at markers of tissue injury, so serum neurofilament light chain, for example, are coming, and there are some early studies that have looked at this. But not surprisingly, that tends to correlate more with just an actual acute attack, not so much about the prediction of whether there's going to be more. So to date, our biggest challenge in MOG-related diseases are that we don't know who's going to relapse and who isn't, and we don't yet have a good way of distinguishing that. There is some evidence, of course, that if your antibody persists over time, that you may be more likely to have further events than if the MOG antibody titers go to zero. But other than that, we really are still needing a better way of distinguishing relapsing from monophasic disease. In neuromyelitis optica spectrum disorder, and specifically here I'm referring to those patients with aquaporin 4 antibodies, this is a serious disease in pediatric and adult patients. Relapses can be devastating with impairment in vision, ultimately impairment of gait and the spinal cord related relapses. So the real biomarker that we need is a way to distinguish which therapy is going to prevent attacks most effectively in a given person. And we don't really have a good biomarker for that. But back to my prior comments on therapy, I think the incredible efficacy of eculizumab in particular lent promise to the idea that highly effective therapies may abrogate the relapsing disease, in which case we don't need a biomarker as much as we need a long-term safety monitoring with these particular treatments.